So without much further ado, we will start the session and invite the first speaker. The first speaker is Dr. Lim Kok Bin. He's a senior urologist at Raffles Specialist Center. And prior to this practice, he was a senior consultant at the Department of Urology at SGH and Director of Andrology Service. Now, Dr. Lim has particular interest in prostate diseases, voiding dysfunction, male infertility, and sexual dysfunction. They train in artificial urinary sphincter and penile prosthesis implantation.
Introduction. I got nothing to declare. When Hoggy asked me to give this talk, I was just wondering how do I phrase it, because I'm a late adoptee of MIS. So hopefully this title won't be too tacky about TURP or not, because essentially we are challenging the gold standard of TURP here. So we urologists love technology. So every time a new technology, a new device, we always try to incorporate into our daily practice. So even with gold standard like TURP, we are abandoning it, obviously because there are some shortcomings. So the question is, what can we substitute that with? And then we have to address the skeptic who feel uncomfortable replacing something they have been doing for the last 2 decades. Hopefully at the end of the talk, the rest of the people sitting on the fence would decide what they choose in the end, either the old ways or the new ways. Now, for anything or any technologies to be implemented widely, you have to satisfy a few criteria. First of all, your concept, your physics has to be sound. The anatomical consideration has to be scientifically proven. So that must have a proof of concept study, which will include sham and placebo comparison, as well as randomized controlled trial against the gold standard, which is TURP here in this case. And then later on, we have cohort studies to look into how to generalize this technology into a widespread practice and to learn any potential harms that comes with it. And later on, with much more high quality papers, you can do systemic reviews and meta-analysis and draw your own conclusion. So why are we abandoning a gold standard such as TURP? Obviously, the most obvious question will be sexual dysfunction. It does come with it. Retrograde ejaculation is something that I always tell people who go for TURP that is obviously going to happen. It doesn't happen. It's probably a rarity. Erectile dysfunction, high percentage of it. So if I have something that can achieve similar outcome as gold standard without those sexual dysfunction, it's probably a much welcome options for these people. And nowadays we talk about personalized medicine. So even if I'm taking medicine and it's helping me in my pee, I may not want to do it for the rest of my life. All right? Or I'm having side effect from the medicine itself. So these are situations that you want to substitute the treatment for, because they are not ready for the TURP. And of course, finally, hopefully with reduced recovery time, because time is money, no hospitalization probably, which is very important nowadays, especially when going through a pandemic. If you have options where a part of the hospital is catering to the pandemic and the other part for outpatient treatment to a majority of people, I mean, that is much more doable than to keep on postponing all the electives. So, as I said, I'm the late adoptees of MIS, and when I was asked to talk about this topic, I went through Google and Medline search and see what last 10 years has come up with. So essentially, there's only 4 main things. Either you have a new energy source, like resume and equablation, mechanical devices like the UroLift or prostate urethral lift, and as well as improvement over technology like the ProLift and the temporary nitinol stent, and finally prostate artery embolization. Now I won't be talking about prostate artery embolization because obviously this is a urology meeting, but to be frank, a number of nice paper comparison with TURP as well as cost effectiveness studies have shown it to be quite a good option, but hopefully that will be left to the right expert to talk about. I'll start with UroLift. Now, some of these slides might be repeat of all the slides we have gone through the last 2 yesterday and today, maybe. I start with UROLIFT because it has good long-term studies, more than 5 years. And later on, to show you that they have fantastic studies comparing sham surgery as well as comparing to TURP. Essentially, it's a permanent implant made of steel and nitinol. And the idea is to place this through the prostate urethra to the outer prostate tissue capsule and to sort of displace the prostate lobe apart, creating a channel for the urine flow. Because there's no resection of prostate tissue, there's no thermal injury, obviously, it really preserves the sexual function. It has some contraindication. Maybe they have new studies, but essentially, I think they have not done much on big prostate gland, that's limitation to 80 gram. Large medium lobe. I know that they do some medium lobe, but the really large grade 3 IPP, I'm not sure. Maybe a new version of the UROLIFT could do that. Obviously, active UTI, hematuria is contraindicated. Has been shown in many studies to be very effective. Those complications are grade 2 and below and self-limiting. The only issue based on the 5-year study was that the retreatment rate is almost about 14% over the 5 years, about 13.6. So, but when it comes to cost-effective analysis, the study shows that is some savings. Unfortunately, if you look into retreatment rate and the money spent on the retreatment, it may not be so. The other thing about UROLIFT is that it's recommended in all the guidelines. So as I go through all the options, this is the only one that is recommended by both the AUA and the EAU. Next, we talk about the resume. It's also quite a long follow-up, about 4 years. To me, it looks similar to tuner, transurethral needle ablation. So in tuner, you use radio frequency. In this case, they use radio frequency to convert water vapor to steam. And the steam will be injected into the prostate to disrupt the cell membrane, leading to apoptosis and necrosis. And the body will take about 3 months to pass out these dead cells. Because the thermal energy is confined within the zonal boundaries of the prostate gland, it minimizes the complications such as a sexual dysfunction. And it can be done with median loop. Has been used in the studies on larger prostate gland. The only setback is that you need a catheter for a week or more. Again, the complications are all grade 2 and below and self-limiting. Shown to be very effective, similar to TURP. Apparently contraindicated in patients with artificial urinary sphincter as well as penile prosthesis. They have good data. They did sham studies before. Retreatment rate is slightly lower, although some report is 4%, but some report is as much as 7% over the last 4 years. Now, in this one, the cost analysis shows that the saving wasn't that much. And it's only recommended in the AUA guidelines so far, not in the EAU. When you look at the cost effectiveness of the outcome, this is one of the papers I've come across. Now, you have to take it with a pinch of salt because this is based on Medicare data from the US side. So what it shows, it compares between water vapor thermal therapy, which is Resume, versus combination treatment oral medicine using generics. That means your 5-alpha reductase inhibitor as well as a alpha blocker. Photoselective vaporization, prostate, and the prostate urethral lift. And you can see at the end of 5 years that water vapor thermal therapy or Resume remains the most cost-effective based on their Medicare research. And you can see that prostate urethral lift at the end of 5 years, the cost went up because of the retreatment. Now, echo ablation is not available in Singapore, but I thought I would talk about it since there's a lot of papers on that. It's essentially a robotic guided, transrectal ultrasound guided hydrodissection of the prostate gland. So you use your transrectal ultrasound to map out the prostate gland and then the software to indicate the range of the prostate you're going to resect. And once you have done that, you hook on the the robotic arm. So this is their own disposable scope with the instrument and robotic arm, and the water jet will essentially go according to what you have marked out and cut off the prostate tissue. The only problem with this is that that's only MI study we have grade 3 and above complication, because you must understand using water jet, so there's no really hemostasis. So sometimes you have to change back to your receptor scope and use a roller ball to stop bleeding. Or in other reports, what they did is they put a catheter and blow out the balloon and just traction for 10 to 20 minutes to stop the bleeding. It can avoid the thermal injury because of the precision of the software in looking at the landmarks that you want to avoid in order to hopefully avoid injuring the nerves. Actually, it's very fast. Most of the study takes less than an hour, but that includes the planning. The actual treatment is probably about 4 to 5 minutes. Done on large scope before, large gland before, you need a catheter, so it's almost equivalent to TURP, and essentially you also need general anesthesia or spinal anesthesia. So that sort of put it at a disadvantage compared to all the MIs, where it can be done under local sedation. They do have a long follow-up, about 5 years, and they have randomized controlled trial against TURP. But they have not done studies on high residual urine or retention of urine, larger prostate gland as well. The study shows there's about 30% reduction in the prostate volume. Although they do claim not much of a side effect in terms of sexual dysfunction, but they do have small number of retrograde ejaculations still. Then you have the protate thermal dilation system, which is the third generation TUMT that incorporates a balloon dilatation. Some of you might have known more about it from yesterday's talk. The problem with this is that when I do the Medline search, I can't find any data before 2012, which means the last 10 years there's nothing on this. So it's not really that new. But happily that recently there was an article just published, which is a multi-institutional retrospective analysis. So over 5 years. So at least I have something to show for the last 5 years. So the advantage of this one is that there's essentially no need a catheter after the surgery. Adverse events all minor, very low. Problem with any microwave therapy is a high retreatment rate. It's probably the highest, more than 14% over the last 5 years. Now I'll finish off with this temporary implantable nitinol device. Not available in Singapore also. This is a second generation device. Basically, this device consists of 3 struts linked together by a nitinol wire. The idea is very simple. So the struts at the 12, 5 and 7 o'clock. And then you place it inside, deploy it inside, and leave it there for 5 days. So the struts will cause necrosis, pressure necrosis of that 3 points. So you end up with this triangular shape widening of the prostate gland. So leave it there for 5 days and then remove it. So you can do a LA sedation implanting the device, but sometimes you may need a bit of a spinal to remove the device. Short study, only about 3 years. Not much a randomized controlled trial against TURP, but they do have a sham study. Shown to be effective, essentially no sexual dysfunction, but there's a 10% failure rate. It means that nothing happened. For about 10% of people, they still get the issue with their enlarged prostate gland, and it's not recommended in any of the guidelines. So in summary, these are the few options you have with their respective dynamics. So you have most of them at least 5 year study, except the nitinol device. Quite a number with sham study and TURP against TURP. Most can be done under LA sedation except equablation. Only Resume has studies showing large prostate gland as well as equablation. Medium lobe, these two, all shown to be effective. All shown to be minimal impact on sexual function, although I think there's still some low risk of ejaculatory dysfunction with Resume and equablation. You need a catheter in Resume, you need a catheter in equablation. None have done study much about acute retention except Resume. Retreatment rate is the highest for ProLive, and then cost savings, not much data at the moment, but UROLIV has recommended by most of the guidelines, resumed only by AUA, ProLief by AUA, but with the provision that you got to warn the patient of the high retreatment rate. So in conclusion, we have newly emerging techniques for BPH that demonstrate comparable result or urological outcome to medical therapy and TURP. The essential thing is that nowadays we are talking about personalized medicine, especially when it comes to preservation of sexual function as a priority for that particular patient. So hopefully with more minimally invasive options emerging, it benefits both the patient and the physician, and we can best advise our patient the best, so-called best fit according to his expectations. With this, I thank you.
Thank you very much, Dr. Lim.
Okay, I would like to introduce our next speaker, Professor Wang. He's an old friend of us. He's been with SUA for many, many years. He is the professor and chair in urology, the director of sexual medicine at University of Texas McGowan Medical School and MD Anderson Cancer Center. And he's going to talk to us on also BPH, the minimal invasive surgery. Ren, thank you.
Thank you. Thank you, Professor Lee and Professor Sam. It was great to be here again. When I look at the program and I saw Professor Lim's talk was about TURP or not, so I thought we're going to get some information about who is going to get a TURP. But luckily, he gave most of my talk already. So he talked about almost every minimally invasive procedure. So it's going to make my life much easier. I'm going to go very quick, but I'm going to go through the different angle. Hopefully, you're going to like it. So we all know that prostate is a gift from God to urologists. That's why we're all here. And we know that since the 2005, the minimally invasive surgery has already replaced TURP and become the most common procedure for the BPH. However, regardless which kind of minimally invasive surgery you use, laser, button TURP, and so forth, there is a pretty high chance to have a sexual side effect. For example, if you do enucleation, more than 75% people is going to have ejaculatory dysfunction. So the true minimally invasive surgery should preserve the patient's sexual function. So therefore, the paradigm of the BPH treatment changed from the 1945, the open prostatectomy, to 2013, we have a new concept called function preservation surgery for BPH. So I'm going to cover all of them, and as Professor Lim talked about earlier, so I'm going to talk about this from different angles. First, we talk about the UROLIFT. Actually, UROLIFT is the leading technology in the arena of function preservation technology. Also set the standard for all minimally invasive surgery in terms of preservation of the sexual function. This is the technology, you can see the results immediately. And very exciting for the urology residents when they come to see the surgery. They say the prostate was blocking the urethra. After the procedure, the urethra is wide open. So we did a surgery 2 days ago. The people, especially the OR nurse, was very excited to see this procedure. And also, when the surgery was performed, we stay away from the neurovascular bundle. And also, we stay away from the blood link. That is why this procedure can preserve the sexual function. And Professor Lim told you about the clinical data. I'm going to show more detail in these slides. Basically, this is the randomized 5-year data from the LIFT study. The bottom line was that you can see the 5 years data, the IPS score improvement, quality of life improvement, and the Qmax improvement are very stable in 5 years. Also, Professor Lim talking about the retreatment rate. Yes, there is some retreatment rate, but it's compared to TURP, it's not so high. The retreatment rate for the UROLIFT is about 2 to 3% per year, compared to the TURP is about 1 to 2%. So it's not too bad at all in terms of its nature of the minimally invasive procedure. And also, there's real world data. This data has more than 14 100 patients and was done in 14 centers. And the bottom line was that this patient are the real-world patient, and if you compare to the LIFT study, their long-term results is almost identical. And understanding that this real-world patient, including the patient has radiation therapy for their prostate cancer, including the patient has urinary retention before. So it's very exciting. And the side effect. Now, I am the one I would like to list every side effect I can. So I find all side effects that's possibly associated with the UroLift procedure. You can tell that the side effect is very, very small, and the most side effect will go away about 2 weeks. And this is probably the most studied technology in BPH arena, especially the minimally invasive surgery. And the publication is tremendous. And right now, in the based on the data from the Teleflex, about 350,000 patients has been treated globally. And the most exciting information I would like to share you is that a few months ago at the AUA, and there's an abstract reported that the UroLift procedure occupied about one-third of the prostate of BPH surgery in the United States. And if you have the background in andrology, I don't know how many people here are specialized in andrology and sexual medicine, you are the one mostly like to use this technology. So it's pretty exciting. And the second technology, as Dr. Lim mentioned, is Resume. Resume is approved by the FDA in 2015, and they used a very smart idea, something called convection versus conduction. And like Dr. Lim was talking about, this is older technology, but they use radio frequency, but they change it to the water vaporization. And it's not really vaporization, the water treatment give the energy. The reason for something called the transduction versus transfixion is that convection versus conduction was that they give the energy in the given area, the energy will distribute very evenly. Instead of conduction, the closer to the energy, the higher chance the heat is higher. So they can basically pretty sure to treat the area that they can almost confirm that they have unified results. And based on the size of the prostate, the treatment location will be different. And again, they have a 5 years data as well, and also the IPS score improvement and the prostate BPH index improvement and the Qmax and all in 5 years is always durable. It's very stable. So what is the real data in the real world? There is a study also recently from the AUA about a few months ago. Is a prospective registry established for 2 high-volume surgeons in 2 centers. So what they found was that basically in this real world, again, that the quality of life improvement and the maximum uroflow and almost identical to the randomized trial. However, you need to remember, pay attention to this. The patient will only reach their maximum therapy results between 3 to 6 months. So before the surgery, you have to tell the patient, don't expect the immediate relief of your symptoms. You have to wait for about 3 to 6 months to see the results. So that's something we needed to tell. And also the contraindication, including if you get a penile implant, I know somebody here specialized in andrology and sexual medicine, you get a sphincter, of course you cannot have that. Of course, some people sphincter, why do you need to do this procedure? Another thing is that this is not 100% sexual function preserved procedure, because about 4% actually in our practice, probably about 9% of people can still have ejaculation dysfunction. That's something we need to remember. And the third technology is aqua beam. Again, aqua beam probably fit into our category function preservation procedure. However, aquabeam does not fit into a category of minimally invasive surgery, as Professor Lim mentioned earlier. I will mention that a little bit later. The good news about this procedure is that they use the robots, pretty fancy name, to attract attention. And also, this procedure can be pre-planned. So you can plan how much adenoma you want to remove with the water jet. And the other thing Professor Lim mentioned that can be done very quickly. You can get the surgery done regardless of the size of the prostate, about 6 minutes. And they have, this is one of the technology, they have the study randomized into the TURP. So the bottom line is that this technology has treatment effect almost identical, if not better, than the TURP. And they have 12 months data. You compare to 12 months data, you look at the symptom score, you look at the quality of life improvement, is almost stable in 12 months. And now they have the 3-year data. The 3-year data was from the retrospective collection of the randomized trial. And what they found was that they compared the patient more than 65 years old or younger than 65 years, they have identical results. In other words, age is not the factor affect this technology in terms of outcome. So the 5-year data now is available for analysis. Again, the results are very stable in terms of IPSS score improvement and in terms of the Qmax improvement. It's not a surprise because this technology basically removes the adenoma of the prostate by the water jet. So the things to think about this technology is that, number one, it is a hospital procedure. Number two, you need a TURP to stop the bleeding most of the time. Number three, you need a Foley catheter. Number four, sometimes you need a blood transfusion. And even though there's no report of de novo erectile dysfunction, however, the ejaculatory dysfunction can be observed in about 27% of the patient. So what about temporary implant lifelong device we call iTind? And this is FDA approved 2 years ago in the United States. As Dr. Lim mentioned earlier, this is the second generation of the device, so I don't have to go too much detail. So what they do is that they put this stand in the 12 o'clock, 7 o'clock, and 5 o'clock. And it's one procedure, put this thing together inside. You can use the flexible scope or you can use the rigid scope to perform this procedure. And this procedure itself is not difficult at all. And the device will live in patient's body for 5 to 7 days. And after the 5 to 7 days, the patient can come to the clinic. You use this special catheter to remove the device. So what the final result is like this use ischemic cuts at the 12 o'clock, 5 o'clock, and 5 o'clock and 7 o'clock. So this ischemic cut is a bloodless, is a compression, and then can have the long-term, improvement of the avoiding pattern. And they have the 3 years data, and the IPSS score improvement is very stable, and Qmax is pretty stable as well in 5 years. The complications, as Professor Lim mentioned earlier, retention, UTI, dysuria, urgency, pain, and hematuria. I have not adopted this technology in my practice yet, and the company has approached me multiple times, but for some reason we have a hard time to get coverage in our hospital. So, what you were talking about, get so many technology, what is the, how are we gonna choose? So what is the data there if we put everything together? So recently there is a systemic review for the all randomized control trial regarding all those technology. And what happened was that if you're talking about IPS score and the flow rate improvement, no doubt about that. TURP and aqua ablation get the best results. If you're talking about the quantity of life improvement, and it's all about the same. But if you're talking about early recovery, return to the work, talking about IIF score, which is sexual function score, the UROLIFT is a winner. And if you're talking about UROLIFT versus the resume, so what is going on here? And this is also just presented at the recent AUA. And basically, this is one center study. They look at all the data. The surgeon like me, we use both technology. And in terms of their IPS score, in terms of their Qmax, those two technology almost identical if you follow them longer enough. The big difference is the 90 days side effect experience. So what happened was that seems like the resume people will have more irritation, will have more problem with the catheter, and very interesting finding was that they said it was UROFAIR has more patient has a clots retention. And I did not say that in my practice, but that's the data, it's data. What is the future? I did not mention anything about ProLive, and somebody asked me a few days ago. Number one is that I never found any publication until Professor Lim showed you earlier. There's a publication just long ago. When I prepare my talk, ProLive has no data. AUA, no data for ProLive. The reason for that, ProLive is a microwave. Microwave has a bad name in the United States because of, surgical failure is so high. And in Texas, I cannot find anybody to use the microwave or use a ProLive at this point. So in the future, we're going to see a lot of technologies coming up: clean range, butterfly, and this catheter stent system, this USI, and the transurethral ultrasound ablation. And that's interesting. The founder of this procedure is Professor Peter Lim. He just showed me and his thing. I said, "Did you get FDA approved?" He said he did. I said, "What day did you get approved?" And he could not give me the dates. But hopefully, he will generate a lot of information. Hopefully, down the road, we can say his technology and see the publication. Also, transperineal laser ablation. I don't really know how you're going to do that, but it's going to come. Regarding the embolization for the prostate, I personally believe this is not the minimally invasive surgery as a urologist, because you're working on the vascular system. If you get a complication, it's going to be tremendous. So the bottom line as a urologist, we want our patient no problem in the restroom. I thought I should use the Singapore Benign for this picture. However, I sent the slides earlier, so I could not use the Singapore Benign for this. And a lot of things, as the physician urologist that specialize in sexual medicine, we want our patient will have no problem in the bedroom. Of course, depends on whose bedroom. Thank you very much for your attention.
Thank you very much, Professor Wang. Our next speaker is Dr. Tan Yong Kang. He's a good friend of mine. He is the medical director of UroHealth Medical Clinic, providing specialized care in prostate cancer, kidney cancers, kidney stone diseases, bladder diseases, and men's health issues. He's a accredited robotic surgeon in MIS laparoscopic procedures. He has also demonstrated his surgical skills in various countries in Southeast Asia and other countries as well. He adopts a holistic approach to patient care with support of his qualified team, and he's running a very successful private practice in Novena, and he's the current president of SUA. We welcome him to talk to us about his strategies to increase patient comfort for transurethral mist.
Thank you. Thanks so much, Hong-Yi, for the introduction. And I want to thank the committee for doing a really excellent job, Fiona and Weta and Kenneth, for transiting from, we gave them the plan to do a hybrid or a virtual, and suddenly we dumped on them the idea of doing a physical meeting. But I think everyone is very appreciative of the work that's been done. So without further ado, let me talk a little bit about strategies to increase patient comfort during MIST. Unfortunately, I tried to do a lit search and lit review, and there's really not much to find out there. So this is more coming out of a personal experience in the last 2 to 3 years with regards to, at meetings, whether they be virtual or in terms of talking to colleagues at work or even internationally about how everyone's been managing the symptoms. So I got some disclosures with NDR Medical and also SG endoscopy. So I think I want to first talk about different types of trauma related to MIST therapies. So we've got thermal trauma, things like conductive, which would be something like ProLive, convective, like Resume, and also mechanical due to punctures and clip positioning with UroLift. I'm not going to talk about the other technologies because really I have no experience, and I haven't been able to talk to anyone about their experiences with those other technologies. So as you know, just a quick look at anatomy. The areas that are potentially affected when we do any of these MIST procedures relate to the areas around the bladder neck, the prostate and the capsule, and also the periprostatic nerves. So this is just some images showing the hypogastric plexus, which actually, if you see, run and form, what we call the neurovascular bundles, which are normally posterior laterally. But if you look at it truly, the nerves are running all around the prostate, even though they do thin out anterior laterally. And they also do run through around the seminal vesicles and to the bladder neck, where they provide sympathetic support towards the bladder neck and functional control. So I broke it up into different things we can think about when we're talking about patient comfort. So firstly, I guess it's pre-treatment. And first thing I want to say is choose the right patient. We talk about personalized medicine, and we have many options for patients, whether a TURP, TUVP, aquablation, and other more MIST-like procedures like ProLift, UroLift, and Resume. And I think we need to find out what the patient truly wants, what's important to them. Because a patient who just wants one-off treatment, maximal improvement in symptom score, least likely to have issues with regards to retreatment, and they're not worried about sexual function, then this may not be the best patient for a MIST procedure, and they may be more inclined towards a TURP. The other question I want to ask you is, or put to you, is don't choose the wrong patient at the same time. So patients who come to you with urinary symptoms but may actually be underlying chronic prostatitis or chronic pelvic pain syndrome may be the group of patients that you may want to give consideration to before you choose to do a MIST procedure, because they may end up, for example, in the case of Resume, patient with chronic prostatitis may end up with abscess formations. Patients with pain syndromes may be the ones that are having prolonged pain post UroLift treatment. So I think carefully about your patients. The use of a cystoscopy, I think, is useful, in particular in patients with a large prostate, where you may want to quantify the intravesical protrusion of the prostate, or in a setting where it is a small prostate and you're thinking, hey, what's going on here? Is it really obstruction, or is it some kind of sphincteric problems? And in that setting also, a urodynamic study may be useful before you go choosing a MIST procedure for them. So I think we've mentioned this a few times, especially at the masterclass. I think we do need to manage patient expectations as to what they are going to get out of these treatments. We talk about functional preservation a lot when we talk about MIST. We do talk about improvement in terms of symptom scores and flow. But are we talking about the same degree as we would get with enucleation and TURP or TUVP? And I will put to you that probably not. And then during the treatment, a few things that you may want to consider doing. We talk about pre-procedural medications. Some practices do give anxiolytics, especially in a setting where you're combining it with local anesthesia as your primary modality of analgesia. So, you can consider giving cold lignocaine if you're using it under local anesthesia. And then you can look at certain kind of periprostatic blocks. We know the usual periprostatic block over here is the one at what we call the Mount Everest, that's where most of the neurovascular bundle runs through, just below the seminal vesicle. But there have also been an idea of something called modified periprostatic block or Beer's block, where apart from the usual place that we place the lignocaine, the other position is above the seminal vesicle, between the bladder and seminal vesicle, and just lateral to the seminal vesicle. So you put in your usual periprostatic block as if you were doing a transrectal biopsy, and then you sweep laterally until the seminal vesicle just disappears, and you advance your needle into the space just below the bladder and put another 2 to 3 cc's of lignocaine into the area. Of course, oftentimes in our practice, it's just easier to get an anesthetist to give a little bit of sedation, whether it be a propofol sedation, because most of our procedures take about 5-10 minutes and then we're done. The other thing in terms of during the treatment process, I just want to talk about recognizing anatomy. I think we want to reduce any kind of impact around the bladder neck, especially with regards to UroLift implants. It's always better to stay a bit further away from the bladder neck. You don't want to place an implant where the capsular tab ends up in the bladder and all that, and then you end up with a lot of chronic pain and dysuria kind of symptoms. You also want to try and avoid the neurovascular bundle, and in this case, I'll give you the example of the median lobe tacking in UroLift, where oftentimes we would retract it towards into the prostatic channel, and then we would push it laterally, either left or right, against the sulcus. And usually the implants are placed slightly below the horizontal. Just be careful that you don't over-angulate or rotate your UroLift device to place it into the neurovascular bundle, because then you may not get the benefits of ejaculatory preservation. I also suggest minimal manipulation of the prostate if possible. So whenever we do a MIST procedure, it's only going to be 10-15 minutes. There's no need to rush the scope in and cause bleeding and stuff like that. So just take your time. The procedure is already so short. You don't really need, you're not going to save any time by rushing to do the procedure. And lastly, I think this was hinted to by Dean Alterman, sometimes less is more. And in the case of Resume, I think some of his data seems to suggest that, injecting less steam may actually end up with less symptoms and similar kind of improvement in IPSS and flow rates. Okay, I move on to post-treatment. The main symptoms, as we've described, are going to be related to urgency, frequency, those dysuria symptoms. Sometimes we get retention of urine. We may get perineal pain, and sometimes patient expectations may not be there. They are expecting to get out of the table and go off to their next activity on the same day, which is probably not a good idea to suggest to them that this is so benign. So I often do use anti-inflammatories like non-steroidal anti-inflammatories just with regards to dysuria. We used to have a drug called Urogesic. Unfortunately, I don't see it much anymore, but I think this may be a good drug to use in terms of the dysuria and the burning sensation related to the procedures. Anticholinergics may be useful, but I just caution in the setting that they may lead to a retention of urine situation. There are some, on some discussion panels, they've talked about using short course steroids, and this is an example. This is methylprednisolone, and Sandor sells a pack, though I'm not sure whether it's available in Singapore because I've actually never given steroids post-procedure. But it's basically a titrated dose of steroids, starting with methylpred of 24 milligrams, and 1, 2, 3, 4, but over 6 days, it drops down to almost no methylpred. And then I think the idea is to reduce symptoms. We can try irrigating the bladder post-procedure with lignocaine and bicarbonate installation. The idea is that the bicarbonate helps to maintain a more alkaline environment and increases the effectiveness of the lignocaine. And lastly, you could use alpha blockers in particular in the setting of Resume, where there's expected to be increased swelling straight after the procedure, which is the reason why we put in catheters. Okay, I just want to quickly talk a little bit about catheters. I mean, obviously the best is no catheter, but sometimes you can't really help the fact that, especially if you're doing Resume, the usual minimal period of catheterization is about 2 to 3 days. And then to get them over the idea of the catheterization, sometimes we do put in a flip flow valve, which is a one-way valve to help control the flow so that they don't have to be on the back. So they just open the valve and then they can pee on their own. I have experimented with some temporary stents, especially in a setting where I have done Resume for bigger prostates like 80 grams and above, and I expect them to be potentially on catheter for 2 weeks. We do not have the spanner temporary stent, though it actually looks quite good. I tried to approach the company, but they think we're part of China and they were worried that we would steal their patent and reproduce a similar stent. And I was like, we're in Singapore, we're not part of China, even though I do look a bit Chinese, but I mean, yeah. So that didn't go very well. But Rocamed brought in a stent called the Exim stent. And this is similar in nature. There is a component, silicone in nature, that sits within the bladder. It has little islets and in the prostate, and then another component within the bulbar urethra. And it's connected by a string all the way out to the penile tip so that you can actually retrieve the stent in the clinic. And this allows the patient to pee as per normal. It's not a bad choice, but I would caution any kind of temporary stent, especially in the setting of hematuria. So if you have a patient, whether it be a UROLIFT patient or resumed patient who has bleeding, I would suggest put on a catheter with a bag so that it is a continuous outflow rather than allow a clot retention situation. With the EXIM stent also, please note that the eyelets are actually smaller than your usual urinary catheter, so sometimes they may get blocked. So just be careful with that. So actually, with that, I come to the end of my talk, and yeah, I just want to thank everyone once again for this opportunity. Thank you.
Thank you, Yong Kan, for your enlightening talk. And we have Lai Kok Eng as our next speaker. He is now a urologist in Gleneagles Hospital. Was in Ng Teng Fong for a long time, and his main interest is in the enucleation with thulium.
Thank you, Prof. Thank you, Prof, for the kind introduction. Thank you, organizing committee, for doing such a wonderful job and inviting me to talk about enucleation. Put it on my slide. I would like to thank Ng Teng Fong Hospital for contributing to my enucleation journey. That's more of a rhetoric, when to operate for BPH. I know there are a lot of young urologists out there who are keen to embark on the enucleation journey. So I'd like to share some of the heart-stopping moments which I had along my journey. So when do we decide to do a TURP, do a bladder outlet obstruction? Obviously, we do know that as men age, the bladder does undergo a time of compensation, then followed by a time of decompensation. In Singapore, most of our patients choose to seek urological care only when they decompensate. And obviously, acute urinary retention is an endpoint that forces us to do a bladder outlet surgery. So obviously, if we showed this slide, which is in Campbell Wash, to our patients, including the complications of what we do to patients, most of them will definitely choose to wait until they decompensate before they even see us. So depending on the practice pattern, acute retention accounts to 5 to 30%. And you can see how you can influence the patient decision based on how you speak and how you convince them for BPH surgery. So obviously AUR is a different endpoint compared to how often we do prostatectomy. I like this diagram from this paper by Peter Gilling. As you can see, enucleation has come a long way. First person to describe enucleation was actually a Japanese in the 1980s, Hiraoka. Yeah, so he was enucleating prostates, and obviously Prof. Peter Gilling then came on with HOLAP, and since then we've been enucleating prostate using various sources. Prof. Fu, my mentor, does TUERP, which is using the Turis. And now, as you can see, the surgeons have moved on to en bloc HOLAP, whereby you can even almost complete the surgery as fast as TURP. So this concept of AEP, anatomic enucleation, has crept into literature, whereby it's a total removal of the transition zone without complications of a simple prostatectomy, with the preservation and of the peripheral zone. So you have minimal permanent incontinence and minimal change of erectile function. Obviously, unfortunately, you most likely cannot preserve the ejaculatory function, which is where MIST comes in. So this is my own HOLAP journey. I joined this very beautiful hospital in 2012. When it's built, I insisted that they have a high power plug that's 32 amperes for heavy lifting for the luminous machine. I went for HMDP, that's in Queen Elizabeth Hospital in Adelaide, whereby Peter Gilling knew Professor Kim already because they were fellow examiners, and went on to start the HOLAP service there. And then it's all of the acquisition of the equipment that you need to complete the surgery, I acquired the Stotz drill cut morcellator, and that's the luminous machine. And in recent times, there's a disposable morcellator as well. So obviously, as with any surgery, you need to know what the complications are, and this pretty much the one of the big series. During the perioperative complications, you can expect capsular perforation, about up to 10%, which is happens with TURP as well. Transfusion rates, bladder injury of note is what you can expect from enucleation because you need to morcellate. And as you can see with the biggest series from Amy Krenberg in the US, 0.1% chance of opening a bladder. I had one case whereby I needed to open the bladder, so I probably need to do 800 more cases to catch up with her. UTI, pretty rare. So again, I think the main complication from enucleation, if you intend to morcellate, is the risk of bladder injury. Post-operative complications of note is the persistent incontinence, SUI and urge incontinence more than 3 months. As you can see, the rate varies. We do know that comes with the learning curve. So again, the need to inform patient of this complication.
With multinodular.
So the problem with prostate
with multinodular adenomas
is that it has multiple adenoma.
If the surgeon considers the three-dimensional shape of the adenoma.
And you can see they're falling on the plane.
Getting into the adenoma and creating new planes.
And you can see that there's an adenoma there. So if you continue on the plane, you will leave the adenoma behind, which is fine. And obviously, I've done it before. This is one of my patients, which I enucleated, and I had to do a flex scope for him because his uroflow, he had detrusor underactivity. So you see, you can see that still I left an adenoma there. So it's not a complete job, even if you think you have done a complete job. So capsular perforation is fairly uncommon. It's related to skill level. In the literature, it's 0.6 to 10%. Most of them do not alter the treatment course. Again, and you can see there's a capsular perforation there. Still fairly good vision. Again, with capsular perforation, significant capsular perforation, you do get more absorption of the fluid during the morcellation. So the trick is to, once you recognize that you have perforated, is to try to avoid extending the perforation so that you can enucleate on a shallower plane. Unfortunately, I think this video does not run. So as we know, there's MIST has come on big time in urological practice. So there will be people who are tempted to do whole lap post-resume. Again, this is a case whereby they illustrated that the fibrosis leads on to a difficult enucleation, whereby there's micro abscesses and you can't really see the plane between the adenoma and the surgical
present
capsule.
a challenge.
Yeah. Now, these are also complications you expect from enucleation, fluid absorption. So you can absorb 200 to 1,000 cc of fluids. So especially if you have capsular perforation, it's a large prostate, you've been operating quite long, is to give Lasix. And obviously there have been case report in literature with severe metabolic acidosis due to fluid absorption. Ureteral orifice injury has also been reported and is higher during the learning curve. I did have one in my first 10 to 20 cases in Ng Teng Fong, whereby the patient actually woke up with frank pain and a CT-QB showed mild hydronephrosis, which resolved without stenting. Again, it's usually due to undermining of the bladder neck and the edema and the extravasation of fluid that causes compression in the UO. So again, we should locate the UOs and again, try not to undermine the bladder neck too much. So bladder injury is pretty scary. It's uncommon, but it happens during morcellation. I didn't show you when the morcellator chewed the bladder, but this is one of my case. It tends to happen at the trigone. Most of them are superficial. It's like a deep TURBT. We seldom see fat from the morcellation injury. They chew off the mucosa. Significant injuries, rare. Open repair if only intraperitoneal. As you can see, hemostasis. Now, if you get a bladder injury and if you still have a remnant edema, like what during the master class in BPH, You can always leave a catheter in and come back to morcellate another day. If you decide to morcellate with a bladder injury, you must understand that there's always tends to be slight over-distension of bladder, and they can absorb quite a bit of fluid. And the case whereby I needed to open the bladder was because I couldn't distend the bladder anymore from a bladder injury. So all these are from early series, whereby enough extravasation of fluid from perforation, and you can actually cause problems for the patient. Again, it's not the bladder perforation, but the extraperitoneal absorption can cause problems. I'll move on to morcellation. And I show this picture because, well, you wouldn't want to see this when you're on a plane. A plane can fly with one engine, but you really don't want to see this when you're on a flight. So success with all endourological procedures requires expertise and instrumentation. So like what Prof. Gomez Sanchez said, yeah, get your management to buy better and better instruments for you. So what kind of things can happen during morcellation? It's almost like, well, I've done national service, it's like cleaning rifles. So you get a blockage of a chip and you can't morcellate anymore. So we sometimes have to clean out the chip from the morcellator. This is a drill cut from Stotts. So sometimes we have to stop the morcellation so that we can do it. This is just to illustrate how frustrating it is. You're at the end of your surgery and nothing happens. Looks exactly like a rabbit tail, and it's truly frustrating because you are in fear that you might morcellate the bladder and yet nothing happens. So you have to troubleshoot whether your suction is adequate. Again, my advice is go slow to go fast. So actually, when you cut down the RPM, so if your RPM is at 2000, drop it down, increase your suction, and actually with enough suction and a slow rotatory speed, you can actually get rid of this. So most of the time it's not speed, it's actually when you slow down your rotary, you'll be able to. So in literature, there are various things which I've tried as well, is to score the adenoma. It's so smooth that it refuses to be chewed on. So you score it so that your morcellator has a chance to chew on the adenoma. But obviously, as you can see, it's a delay of your surgery because it just frustrates you. It's quite frustrating when you cannot just morcellate this 2 grams of prostate out. And again, I know why Prof. Wu made me do TURP. Well, you can go back to a TUR of the adenoma as a last resort. But again, there's the risk of bladder injury with such maneuvers. You can bring it into the prostatic fossa to get rid of that finer one. So again, this is a paper which shows the various methods that people use to take out the adenoma after they have enucleated it. And a lot of people do this mushroom technique whereby they leave the adenoma attached to the bladder neck and then do a TUR and get rid of the adenoma. So I think for people embarking on enucleation, this is a fantastic technique as well. You enucleate and then you use a TUR to get rid of the adenoma at the end. So again, this is the flow chart of what they do when the machine breaks down. Use the mushroom technique, or in worst case scenario, you do a laparotomy, which is not ideal, or you bring back the patient when the machine is working. So again, MIST. HoLAP after UroLift has been reported in the literature. So as you can see, the main problem comes with the fact that you have these foreign body within the prostate, and these foreign body will then get caught in your morcellator. So the main problem is the metal clips will actually blunt or jam your morcellator blade, and you wouldn't. And as we know, morcellation is already stressful enough. I think if patient has a UroLift, probably just do a TURP after that. So these are the morcellations equipment that we have. The Piranha is actually the best morcellator according to literature as well, but it's quite costly. The Luminis has the VersaCut, and the drill cut is from Stotts. This instrument that I show on the bottom right is actually a very useful equipment that I used during my HNDP. Still trying to find it. It's actually called adenoma. It's a crown loop whereby it has jaws which catch the adenoma. So usually finishing the morcellation with that small piece of adenoma is the main problem. So you just use a crown loop retrieval, and you actually save you the stress of trying to morcellate the rest of the bits. So I come to the end of the intraoperative scares. So obviously we need to counsel patients adequately as well to what to expect post-operatively. So urinary incontinence being the main complication, and it's very common immediately post-op, and it's usually urge incontinence, and it's the most common complication with various reported rates. Pure stress is rare and is usually related to the learning curve, and there have been studies whereby previous pelvic floor training exercise may help facilitate recovery. For myself, if it's urge incontinence, I do start them on anticholinergics as early as 2 weeks to 4 weeks, depending on how bothered they are after the surgery. Now, early apical release may help, and I think it actually does help. Again, Prof. Sancha did mention his early apical release helping continence. So I do try to do an early apical release when I can. So again, this is from Emmy Krenberg's unit, and they have this questionnaire which helps to, again, it's important to let patients know what to expect after surgery. Number one, you should expect some dysuria, you should expect some urine leakage, and there might be a period of days to weeks that you might still have blood in your urine, and obviously it will affect your ejaculation or reduce ejaculation after that. So for people embarking on an enucleation journey, obviously choose an appropriate size, usually 30 to 50 grams. Roughly, they will have a fairly nice plane. Again, case selection is important. Try to find a proctor and then and go on the enucleation journey. This is a paper written by the OSTEC from the AUU. UAA. So again, a lot of things have been said about learning curve, but actually if you look at this table from EAU, a TURP learning curve is 30 to 50 cases, and the whole lab is also about there. So it's more of embarking on the journey to find the learning curve. In my own center in Ng Teng Fong, before I left, I have proctored a few of our juniors to do whole lab, and I'm quite happy that they're doing it independently as well. So some advice for starting out, too small a prostate is actually difficult to find a plane, a normal BMI patient, and try to limit bleeding by avoid those with catheters and avoid those with infection. You have to do a regular case so you're not reinventing the wheel every time. And again, equipment. And this jug that I show on the right is actually a 18-liter suction canister, which I'm still trying to find and have. The problem with our small suction canister is every time you change the suction canister, you lose the suction and you can't morcellate. Thank you very much for your time.
Thank you, Koh Ying, and I would like to thank all our speakers for this session. Thank you for your attendance.